Good evening, friends. Good evening, sir. Good evening, all the senior faculty here. I could see Professor Endaria, Professor Nishikant Gujar, Dr. Robin, and I expect others to come in. Sir, this is sorry, the 256th edition, and we are running the 502nd case for the PG clinics. So we have the honor of having Professor Jagmohan sir from NDMC Medical College as a invited faculty, kindly contributed and recommended by Dr. Rajiv Nandan Sahai sir. And we are expecting Professor Ratna Chopra to join us shortly. And today's PG is Dr. Dinesh, kindly contributed by Professor SP Gayatri ma'am, the professor and head of the department from Government Stanley Medical College. Today we have a very important case to be presented, Parotid tumor, and it will be moderated by the inviter faculty. And of course, our own faculty will also be joining into chip it. Friends, the format of presentation will be, the candidate will run through the history without halting. Once he completes the history, the faculty can visit slide after slide from first slide. They can give questions or they can give you their comments. I request the faculty to kindly give answers if the candidate is not expecting or answering to your expectation, so that this becomes a teaching mode rather than an exam mode. Then the same thing happens through the clinical presentation, and beyond which they are taken through the investigation, surgery and complications and recent advances, if any. We have an hour for this case, and we'll be happy to help you if there is anything. And there's been a lot of inputs from the people who have taken the National Board Theory exam last week. They have shown their respect for all the discussions which has happened in the last year through this forum. And I wish all the best for the people who are going to give theory exams, who are in the exam going, or are already in the various levels of study leaves and presentation, because many universities have announced their dates. So we look forward to having you on board, and those who are willing to present in this forum are welcome to contact in the number given in the flyer. And we wish the best for the presenter today. And on behalf of all the senior faculty here, and my dear friends, do well in the exams. I'm sure I recommend you continue the same efforts for the March NEET SS program, and that becomes your next step towards your life career. Good luck to all of you, and I wish the best for Dinesh for today's presentation. Faculty, please take over. Dr. Nishikant Gujar sir has kindly been requested to run the meeting for this evening. Nishi sir, please take over, sir.
Yes, sir. Thank you, sir. Thank you, sir.
I think we have Ratna ma'am also here. Warm welcome, ma'am. Thank you for joining us in spite of a very short notice and in spite of your busy schedule. We are just starting the session, ma'am.
For the invite.
Thank you, ma'am. Thank you.
Good evening, madam. Dinesh?
Yes, sir.
Dr. Dinesh?
Yes, sir. Good evening, sir.
You are going to present the case of parotid tumor.
Yes, sir.
Please start presenting and finish your history and summary. Then our national faculty over the presentation will ask questions. Don't worry, it will be a practice session rather than your final exam. As this is a practice session, don't worry about the mistake.
Okay, sir. Sure, sir. Shall I proceed, sir?
Start.
Shall I proceed? Please.
Start the presentation.
Good evening, one and all. Myself, Dr. Dinesh, final year postgraduate from Government Stanley Medical College from Chennai. I'm here to present a case on parotid swelling, guided by my professor and head of department, Dr. SP Gayatri ma'am, and my unit chief, Professor Dr. T. Babu Antony, sir.
Move to the next slide.
Mr. X, a 36-year male, resident of Rayapuram, working in a bookshop, came with complaints of swelling below the left ear for past 1 year. This is a clinical image of the patient. History on presenting illness. Patient was apparently normal 1 year ago, following which he noticed a swelling below the left ear, which was insidious in onset, initially small in size about 1 inch, and gradually increased over past 1 year to attain the current size. The swelling is not associated with pain. No history of any variation in the size of the swelling with food intake. No history of fever. No history of ear pain. No history of difficulty in swallowing or opening the mouth. No history of rapid increase in size of the swelling. No history of ulceration in the overlying skin. No history of cough with hemoptysis. No history of drooling of saliva, asymmetry of face, or difficulty in chewing food, or difficulty in closing the eyelids. No history of dryness of mouth and eyes or joint pain. No history of any other swelling in the head and neck. No history of any ulcer or swelling in the scalp. Past history, no history of similar complaints in the past. No history of previous irradiation. No history of chronic drug intake. Comorbid history, no comorbidities. And personal history, he consumes non-vegetarian diet, takes alcohol occasionally for the past 8 years, once a week. Betel nut sugar for the past 10 years. He takes around 4 to 5 nuts per day. Not a smoker, normal bowel and bladder movements, has normal sleep cycle. Summary, a 36-year male presented with complaints of swelling in the left parotid region for past 1 year, which was gradually increasing in size with no significant history.
Yeah, there's a lot that has been covered in the history. Can we come to the first slide?
Yes, ma'am.
What are the other swellings that can be present below the ear lobule? You said this is a swelling which
below
is
the-
present below the ear lobule. So what is the swelling that you're thinking in terms of, and can there be other swellings in this area?
In this area, the probable causes of swelling may be arising from parotid gland, any lipomass, any sebaceous cyst, any dermoid, or any tumors arising from the bone.
Based on the
What is-
history, is it possible to differentiate it from swelling at the lower pole of the parotid? Can we go to the image? Is the swelling just below the ear lobule, or is it extending to some other areas?
Below, front, and back of the ear lobule.
Yeah. So is there, if the patient gave you a history, is it just below the ear lobule or is going behind it also? Could it have made a difference?
Yes, ma'am. If the swelling extends behind the ear lobule, by obliterating the groove and all, it might be a parotid etiology.
Yeah. So what are the, other than the lipomas and soft tissue swellings, is there any other swelling that needs to be differentiated from, which is present in the parotid area also, but the cause could be something else?
Maybe nodal enlargements, secondaries.
So you've taken the history, but can you highlight for others at what history have you taken to rule out any pathology in the drainage area of parotid lymph nodes?
For ruling out any lymph node enlargement, I have asked it for the any ulcer or the swelling in the scalp region, and
Yeah.
then any other swelling in the head and neck region.
Yes. What is the significance of smoking in your patient?
Smoking increases the incidence of benign parotid tumors like Warthin's, and also smoking also increases the incidence of malignancy in the upper aerodigestive tract, which may present as secondary SNP.
Very good. What is this term which is called first bite syndrome? What is this first bite syndrome? So there are other pathologies or post-operative sequelae in which as soon as the patient eats and there is eats, with each bite there is pain. As soon as the patient starts happening, the cause is musculoskeletal.
Okay.
Right? Yeah. So have you taken history of any previous surgery in this patient?
No reason
You make
previous surgeries.
So what is the significance of asking for any history of previous and what previous surgery did you ask for?
Any previous surgery for any swellings in the head and neck region, any ulcers in the oral cavity, any?
Yeah, so one would do
tonic-
surgery related to any surgery in this area only, which would point towards a recurrent parotid swelling or swelling in the drainage area, or surgery for swelling in the drainage area of the parotid lymph nodes. Right.
Okay.
What is the significance of previous irradiation?
Irradiation also increases the risk of tumor in head and neck regions.
Yeah. So is there any other faculty member who may want
Dr.
to ask
Dinesh?
a question?
Good evening, ma'am.
Yes, sir.
Yeah, please.
Dr. Dinesh, can you name some recurrent swelling of parotid region? Recurrent swellings of the parotid region. You've taken, there is no previous history of similar complaints. Do you know any swelling of parotid region which is recurrent?
Pleomorphic adenoma will cause recurrent swelling, sir, and any malignancies will cause recurrent swelling, sir.
Anything else? Which madam was asking, you said malignant lymph node.
Lymph nodes.
No, not malignant. They can be preauricular lymphadenopathy, inflammatory even, scalp and auricular, even orbital region. They can give rise to preauricular lymphadenopathy. And idiopathic silosis can even be recurrent.
Okay, sir.
What is
What
the
is the
importance?
significance of male sex in this case? You said this is, your case is male patient.
Yes, sir.
What is the relation with relation of gender in your case? Any significance of gender in this case?
Male sex have a high risk for developing Barthen's tumor.
Did I miss it? Did you?
Any
Please
yes,
continue, Dr. Jagmohan.
any significance of HIV in parotid swelling?
Yes, sir. In HIV, due to the ART drugs, it results in the bilateral parotid swelling, silocasis.
Lymphoepithelial tumors are more common in
Lymphoepithelial
HIV
tumors are also
patients.
more common.
Dinesh,
Yes, sir.
please go to the first slide.
Yes, sir.
You have mentioned that there is no history of variation of size of the swelling with the food intake. What is the significance of this?
In benign conditions, inflammatory conditions, in case of any sialidinosis, once a patient takes food now, because of the increased salivary secretions, there will be an increase in size of the swellings are associated with the pain.
Whether this point is relevant to this case, or where is the site of swelling in this case? Swelling
For
is
this
below the
patient,
ear and around the ear.
no,
Hello.
sir, for this patient, it's less chance, sir, to be a sialidinitis.
Okay. Why you ask history of ear pain?
Because of inflammatory
Ear
conditions, there
pain,
will be
ear
referred
is
pain.
swelling. What you want to rule out?
By ear pain, I need to rule out any inflammatory pathologies or any malignant tumor. In case of it's a malignant tumor, whether it's infiltrating the nerve or not. By difficulty in swallowing, I need to rule out whether the deep lobe is involved or not. And
As there is a swelling
by
below the
difficulty
ear. Please listen. As there is a swelling below the ear lobe. Give me the 2 or 3 differential diagnosis by your history. A different condition we have to explore. Just now, madam asked the same question to you.
swelling
What
below the
are the
ear,
possible reasons?
the
One is the
possibilities
parotid.
could be
Second,
parotid, any lymph node, any lipoma in that region.
any lymph node. Very good. Which lymph node you are suspecting? Any lymph node swelling. Okay. Then why you ask history of difficulty in solving?
In case of parotid, whether I need to rule out whether the deep lobe is involved or not, sir. So I asked for it.
Is it only lymph node or something else? Involvement of deep lobe may
Deep
cause
lobe, sir.
difficulty swelling. What is the association of pain? If swelling is associated with pain, what do you think? What it can be?
It could be inflammatory conditions like sialidinitis.
In
If
a
it is
parotid swelling, in a long-standing swelling, if there is pain, then what do you think?
malignant transformations of the swelling.
And what are the conditions when there can be pain in benign swellings?
In benign
Are
swellings,
there any conditions?
parotid abscess and parotitis.
What else? That will with the onset they will be painful. Parotid abscess and parotid inflammation will be painful from the onset. If a swelling become painful, this is
There will
with
be any necrosis of the
one is necrosis, stretching of capsule,
stretching of the capsule.
involvement of nerves, and all other things. They are usually with all the swellings.
Any hemorrhage.
What is your provisional diagnosis after you complete your history?
By the history, it's probably a swelling arising from the parotid tumor. Mostly it will be a benign tumor, pleomorphic adenoma.
Pleomorphic adenoma.
Yes, sir.
Despite the it is common in female, it is a male patient.
Yes, sir.
Though it is common, but points in favor of pleomorphic adenoma.
Because it's a first of all, it's a benign swelling, sir. It's gradually increasing over the past 1 year, and there's no symptoms related to malignancy, and it's typically occupying the region of parotid. So most common benign tumor is pleomorphic adenoma. So I'm going with pleomorphic adenomas.
Is 1 year a long duration swelling? I think if it is increased to this size over a period of 1 year only, it is a rapid increase in the size of the swelling. Any take of other examiners on this? He never had a swelling in this area, and just over a period of 1 year, it has increased to the current size that you've mentioned. Hello, am I audible?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Yeah. So I think 1 year history is a history of relatively rapid increase in size of the swelling.
Okay.
What are the histories that you took for to rule out malignant change in this swelling?
History of pain, history of suggestion of facial palsy, any skin changes over the swelling.
Any alteration in yeah, go ahead.
Difficulty in opening the mouth.
Yeah. So all these were not present, right? And so that is why you're thinking. You're correct, actually, because none of these features is present. So you are keeping in mind it's a benign swelling in spite of the fact that it is increased in size over a period of 1 year. Any differential diagnosis?
It could be since the age is 36, it could be if at all it's a malignancy, it could be a mycopedomer carcinoma.
Okay. You've just taken the history as of now, no? And here you can keep in mind that there can be other swellings also, like we talked of, which could be present in this area, like
lipomas, second nodal enlargement.
Yeah. So you would want to examine further to be able to know the nature of the swelling. Yeah.
Yes, ma'am.
Yes. So can you describe the classical pain that happens in a salivary colic?
In salivary colic, the pain will be whenever the patient takes food, there will be increase in the nature of the pain associated with the increase in the size of the swelling will be there.
Yeah. Can we move to examination?
Yes, ma'am.
Yeah.
On general examination, the patient is examined in a well-lit room and consent has been obtained. Patient is conscious, oriented to time, place, and person. Patient is moderately built and nourished. No pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. Vitals is stable. On local examination, on inspection, there's a single swelling of size approximately 5 to 6 centimeters seen below, front, and behind the left ear. Ovoid in shape, Surface appears irregular, margins well defined, extending superiorly up to the level of the tragus, anteriorly 2 cm in front of the tragus, posteriorly till the mastoid process, inferiorly border is up to the level of the mandible. There is obliteration of the retromandibular groove. The lifting of the left earlobe by the swelling is seen. Skin over the swelling is normal. Swelling becomes more prominent on asking the patient to clench the teeth and less prominent on opening the mouth. No swelling in the right parotid region. No other visible swelling in the neck. An examination of oral cavity. There's no trismus. Oral hygiene is fair. Nicotine staining is seen in the teeth. All the parts of oral cavity is normal. No fullness in the left tonsillar fossa. Opening of the Stenson duct. No inflammation is seen at the site of orifice. In palpation, no warmth or tenderness over the swelling. A single swelling of size 5 x 6 cm, ovoid in shape in the left parotid region. Superiorly extending till the level of tragus, anteriorly 2 cm from the tragus, posteriorly till the mastoid process, and inferiorly border is up to till the level of the mandible, angle of mandible. Borders are well defined, surface is nodular, consistency is variable. Skin over the swelling is mobile, curtains in positive. Bidigital palpation of the parotid duct is normal. Facial nerve examination is normal. No evidence of any weakness. Examination of neck, no cervical lymphadenopathy present. Examination of other salivary glands is normal. Systemic examination is normal. My provisional diagnosis is benign tumor involving the left parotid, probably pleomorphic adenoma.
Yeah, again, a very well presented clinical examination. Most of the points have been included. Can we move to your first slide of examination again?
Okay.
Go to general physical examination. Yeah, what do you mean by the term generalized lymphadenopathy?
Involvement of two or more than two group of lymph nodes.
Involvement of two or more non-contiguous groups of lymph nodes.
Non-contiguous.
Right. So, do we have examination of scalp in your examination findings? Have you written examination of scalp, examination of pinna, and examination of facial skin? It is good to mention because you have a swelling in the parotid area, so drainage area must be covered, right? Let's come to regional examination. You may stop calling it local examination and call it regional examination of head and neck and parotid area, right?
Okay.
So, yeah. So, what about the examination of oral cavity here? We'll come back to the swelling. So, you describe a panoramic view of examination first, talking about the symmetry of the face and that you could visualize the swelling in the parotid area, more so in the lower part of the parotid area, right? And then you can come to the swelling examination of swelling itself. Here it looks like we've done a focused examination of just the swelling. Is the whole parotid involved in the swelling, or is there a swelling on one pole of the parotid?
Almost whole parotid has been involved.
So is
Tail
it
region is not
sorry? Sorry, couldn't hear
tail
you.
region is not. It seems like whole parotid has been involved.
So whole parotid is uniformly involved, right?
Yes, ma'am. The swelling extends both front and behind the ear.
So what is the significance of talking about the fact that it is 2 centimeters away from the tragus? So normally there is a
anterior
groove. Yeah. Yes, tell me.
It's the anterior extent of the tumor and
This is already, you need not describe the geographical location of the tumor like that, but there is a significance of the groove between the swelling and the tragus. Because if the
like
groove
this.
is, yes, if the groove is present, because parotid is present beneath the parotid fascia, right? So there will be a groove that will be present there. And the retromandibular area hollow will be obliterated. While the hollow anterior to the tragus may be preserved
Present.
here. Yeah. So you said the surface is irregular. So what about the consistency of the swelling? Is it of a uniform firm consistency, or is it a variable?
Variable consistency.
It has a variable variation is from what to what? What have you written about the variability of consistency?
In some parts it's firm and some parts it's cystic in consistency.
All right. So what interpretation do you gain from this?
Since the swelling is since the consistency is from firm and cystic,
So you're thinking
more
that is why you are thinking in terms of a pleomorphic adenoma is your diagnosis, right? What is the sign called curtain sign?
curtain sign is to see whether the swelling is moving above the zygomatic, superior to the zygomatic arch or not. In case of if it's parotid, it won't move beyond the zygomatic arch, since it's deep to the parotid fascia.
Yeah, what is the upper limit of attachment of parotid fascia?
The parotid fascia, after encircling the parotid gland, it gets attached to the zygomatic arch.
Yeah.
Lower
So
part of the zygomatic arch.
Right. So is curtain sign relevant in this particular case?
It
is not really relevant in this particular case because swelling is present at the lower pole beneath the ear lobule. It is unlikely that you will be able to take this swelling above to the level of zygoma. Yeah. So which muscle did you check when you were asking the patient to squeeze or clench the eyes?
masseter.
Eyes.
Orbicularis oculi.
Right. And what about the oral cavity? What are the muscles that you check with respect to the oral cavity?
Orbicularis oculi, vaccinator muscles.
Orbicularis oris and
vaccinator muscles.
Okay, vaccinator is for the cheek, right? And for the angle of the mouth?
Depressor angli oris and levator angli oris.
Yes. So, what aspect of the oral cavity function would be lost if orbicularis oris is denervated?
Those movements associated with the expressions of the face will be lost.
With orbicularis oris, oral competence will be lost, right? Yeah. So what are all these muscles? In which plane are they present?
Subcutaneous plane.
They're all in the subdermal area, right? Like platysma. So all the muscles of facial expression are present here only. What is this complex called in the face? Do you have a very well-defined subcutaneous plane in the face?
Superficial musculo-upper system.
Yes, very good. Excellent. Right. So now how did you palpate for the parotid duct?
By digital method, I will palpate the parotid duct just anterior to the muscle.
So there are two parts to the parotid duct. One is that you ask the patient to clench the teeth and you run your finger along the anterior border of masseter. There at the midpoint, you will be able to roll your finger over the duct. But there is a submucosal part of the duct also that can be palpated by digital examination. Where exactly is the opening of Stenson's duct?
Opposite to the second molar, upper second molar.
To the crown of second molar tooth in the cheek, right? Yeah. And what did you make a mention of the fact that the other salivary duct openings were normal and that no other salivary gland was palpable?
Yes, ma'am. Examination of other salivary.
You made a mention of it in your examination. I missed it, I think. Have you written it?
Yes, ma'am. Other salivary gland.
You can just tell me if you've written it. Have you written it?
Yes, ma'am.
Okay. And what about the lacrimal glands? Are they visible or palpable in this patient?
What glands, ma'am?
Lacrimal glands.
No, ma'am. They're
Have
not
you made a
enlarged.
mention of them?
Ma'am?
Have you made a mention of lacrimal glands in your examination findings? That they're not enlarged?
No, ma'am.
So why is it important to talk about them? Even in history?
In some conditions like Sjogren syndrome and
Yeah.
Mikulicz syndrome, associated involvement of lacrimal glands will be there.
Yeah, so we must that is why we talk about facial symmetry also, so that in case there is any other swelling, you would talk about it. And these swellings, the other parotid, other salivary glands, lacrimal glands, and lymph nodes, they must be specifically mentioned. Yeah. So what examination did you do for the deep lobe?
If the deep lobe is involved on inspection, there will be a medial displacement of the tonsillar region.
Any role of doing a bidigital examination for that?
By doing a bidigital examination, we can confirm the enlargement of the deep lobe.
So it is only if you find any asymmetry would you want to do a bidigital examination. Otherwise, you may not do it. Right? So what are the other swellings which can push the tonsil to the other side? Or displace the tonsil?
Any paratonsillar abscess, any
That
swelling
will be
in
an
the
acutely painful condition, no? Are there other painless conditions also that may push or deviate the position of tonsil? So when you find any swelling in that area, you have to have a high index of suspicion of ruling out a parapharyngeal space tumor also. And when we talked about difficulty in swallowing, that is another thing that you have to keep in mind, that parapharyngeal tumors may have similar presentation to deep lobe parotid tumors.
Okay.
Yeah. So examination of ear was normal.
Yes, ma'am.
You made a mention that the swelling is extending till the mastoid.
Yes, ma'am.
So how does it affect your management? The swelling you said is extending till the mastoid.
In management during surgery, the incision should be extended till the mastoid.
No, incision
Somewhat.
anyways goes till the mastoid. So if there is a large swelling which is overlying the mastoid, identification of facial nerve may require some special maneuvers. We will talk about it when we will manage. I would request Dr. Jagmohan and Dr. Rishi to take over, please. I intend to continue to speak. Dr. Jagmohan, is Dr. Jagmohan there?
Yes, ma'am.
Yeah, please ask him a few questions, please.
Dr. Dinesh,
Sir.
you have made a diagnosis of pleomorphic adenoma in view of your history of a male patient with variegated consistency with solid and cystic component. Is there
Yes,
any
sir.
chance of change in some other diagnosis? Beside pleomorphic adenoma, though, although it is most common tumor with variegated appearance, solid and cystic areas, and male patient, what else it can be?
It could be a mucoepidermoid carcinoma.
Any other benign tumor which is common in male with cystic component?
Warthin's tumor, sir.
Yeah.
For this tumor.
What is dumbbell tumor?
The pleomorphic adenoma of the salivary gland involving both superficial and the deep lobe.
It is a tumor of deep lobe with swelling in neck as well as in Patty's canal. Are you aware of Patty's canal?
Sir, in between the styloid and the
Mandible.
mandible.
Ramus of mandible.
Dinesh, how will you
Yes, sir.
suspect malignancy in patient with a pleomorphic adenoma?
If it's a malignancy, there will be a sudden rapid increase in size of the swelling, which was previously static or slow growing. There will be a pain.
Okay, very good. What are the
there will
other
be a
features suggest of malignancy? One is a sudden enlargement in size. Second,
second pain, nodal enlargements. So nodal enlargements will be there. Facial nerve palsy and
ulceration.
involvement of
Yes, no, madam also covered that point. Ulceration. Any other thing?
ulceration, muscle involvement and temporomandibular joint involvement.
Facial
will
nerve
be there.
palsy.
Facial nerve palsy, sir.
Facial nerve palsy.
Yes, sir.
Any benign tumor of the parotid that is associated with smoking?
Warthin's tumor, sir.
Warthin's tumor. How will you diagnose it? Whether
Usually
it
Warthin's
is
tumor
arises from the upper lobe or lower lobe of the parotid?
is more common in the tail of the parotid, sir.
Okay. And how will you diagnose it? Any scan?
There will be a technetium system. The technique
It
scan.
shows the hot spot in a technetium 99 scan. Okay.
Dinesh, what are the, you have written as other salivary gland regions were examined. What are the regions you examined?
I examined for the contralateral parotid region, submandibular regions, and the floor of the mouth and oral cavities.
So what are the common areas where you get an oral cavity?
Hard
Other
palate,
than the minor salivary glands, commonly where you look?
I will most common tumor in minor salivary glands will be in hard palates.
So you examined the hot palate also?
Yes, sir.
So what is the possibility of accessory salivary glands? Especially parotid?
Its incidence is around 20 to 30%.
So
it's
what do you
along the
mean by
duct of
accessory parotid glands?
It's a parenchymal tissue, parotid parenchyma that has been no connection with the main parenchyma. Usually present around the distal to the gland around the parotid duct. Sir.
So you have examined the curtain sign also, no?
Yes, sir.
What is that mechanism?
In curtain sign, in case of parotid, as it's deep to the parotid fascia.
What is that curtain?
The zygomatic arch.
Zygomatic arch. What is that? What is there fixed there?
Parotid fascia, sir.
Parotid fascia.
Investing layer of deep cervical fascia.
So how many layers has deep cervical fascia?
It splits into two and encircles the parotid gland and attaches it to the zygomatic arch.
That is an investing layer.
Yes, sir.
What are the glands it invests? What are the muscles it invests?
It invests the submandibular gland and the parotid gland, and it invests the trapezius muscle and sternocleidomastoid muscles.
It is not investing the thyroid?
No, sir.
So then what is investing thyroid?
Pretracheal fascia.
So what is that layer? Pretracheal fascia?
It is also another component of the deep fascia of the neck region.
How many components are there in the deep cervical fascia?
3 components.
3 components. And the
Three
first
or
is
4,
layer, then
Sir?
pretracheal fascia. Yeah, investing layer, you are right. Investing layer, pretracheal fascia, and then prevertebral fascia you have. So
yes,
can you trace this investing layer?
Investing layer of deep cervical fascia, superiorly it starts from the occipital protuberance and mastoid and then mandible, sir. Posterior to anterior, and inferiorly it's get attached to the C7 vertebra and spine of scapula and clavicle, sir.
What is Burn's space?
It's a space between the 2 layers of investing layer deep cervical fascia, just superior to the sternal notch.
So good, you are answering. What is inverted curtain sign? In a glossopharyngeal nerve involvement, you can see that soft palate will be upturned, otherwise known as upturned curtain sign. You can get that curtain sign also. So in this case, why do you think it is to be a benign? It's not a malignant.
By history wise and also by examination, there is no feature suggestion of malignancies.
What features you are looking for?
By history, there's no pain, no facial palsies, And then the skin swelling is mobile. There is no other swelling in the neck region. There's no lymph nodes are palpable. No evidence of muscle infiltrations or the temporomandibular joint infiltrations.
Oh, so what is the region, local node you will look for in a parotid?
In parotid, the first the intraparotid and preauricular nodes will be involved, and then level 2 and level 2, 3, and 5A will be involved.
So pain is a feature of malignancy?
Yes, sir. Due to the in malignancy, because of the stretch of the capsule, in case of any necrosis or hemorrhage inside the tumor.
Benign swelling will not stretch the capsule?
Yes, sir. If it is too large, it will stretch the capsule.
Okay.
What are
What
the,
of
what
Yeah,
are
madam,
the
please.
ways? Yeah. What are the ways by which skin can get involved in a parotid swelling?
By either by lymph nodal enlargement and extracapsular extension of the lymph nodes that will extend to the subdermal lymphatics, and skin can be involved, or by the direct infiltration of the malignancy from the gland can be involved.
Can a benign swelling cause an ulceration of skin in parotid swellings?
If it's massive swelling, the size of the swelling is too big, it may result in the pressure and decreased vascularity, and also may occur.
Is there any clinical examination technique by which you can differentiate a benign ulcer from a malignant ulcer? What is this probe test?
By examining the margins of the ulcer.
Yes, if you can pass a probe beneath it, it's more likely to be due to pressure necrosis. Yeah.
Can you get metastasis in benign swelling?
Very rarely in pleomorphic adenoma.
So there is a variety called metastasizing pleomorphic.
Yes.
You can get much later also, that maybe even if you get a benign swelling, you can get it there. So you said you have looked for the other clan for the Zika syndrome.
Yes, sir.
And what is the other thing? One is Mikulicz.
Mikulicz syndrome.
What is the difference between the two?
Mikulicz syndrome is a variant of the Sjogren syndrome. It may be associated with other systemic conditions like leukemia, lymphomas. Whereas in Mikulicz syndrome, the antibodies will be negative, and the Sjogren syndrome, the antibodies will be positive.
So in a clinical outcome, which is better?
Okay. Mikulicz is better.
Mikulicz is better because apoptosis will not be there. The cells will not go for die. There is a possibility when you correct the condition, whether it's a tuberculosis or sarcoidosis, whatever the Mikulicz. So you will be able to reverse it. The conditions can be there. So how you are going to proceed now?
So are there you talked about lipoma in this area. Can there be any other swelling which may cause a nerve deficit and is present in the parotid area?
Any lymph node enlargement, lymphadenopathies.
So there can be swellings arising from the nerve itself.
Schwannomas.
Neurofibromas in this area,
Yes.
or associated malignant swellings from the nerve can also lead to nerve deficits here and present with a lump also.
Okay.
So what is, like, going back to basics of MBBS, if there's a swelling along the nerve and if there's a swelling arising from a soft tissue, how do you clinically differentiate between the two?
If the swelling is arising from the soft tissue, it will be mobile in all directions, ma'am. If it is arising from the nerve, it will be mobile only in the perpendicular to the fibers of the nerve.
Right.
Can
Any other?
Can it be a hemangioma?
No, sir. Hemangioma is more common in the pediatric age group, and by this age, it's very less common.
Especially when the patient is biting or masticating, the gland will swell. Turkey weight, there's a sign called Turkey wattle sign. It will be the bluish discoloration and it will be producing like a hemangioma. There are a lot of tumors, benign tumors were listed, but though we talk only on the pleomorphoadenoma. So, madam was asking on you to some other question that I just didn't.
Yeah, that is fine. So, other than that, during examination, you may find that there is tingling along the nerves
Yes, ma'am.
as a part of clinical. Can we move to how will you manage this case?
Please, go ahead.
Yeah, how will you manage this case?
I will proceed with the basic investigations and
By
ultrasonogram
what
of
do
the
you know? That's not a good way to answer, no? What do you mean you'll proceed with basic investigations?
routine blood investigations.
No, first is that you would explain the patient condition to the patient, and then you would do investigations to confirm your diagnosis first.
There is this point we are repeatedly making in this PG clinics. And do not come with a routine investigation. It is only the first, your approach is always to clinically confirm your diagnosis.
I will go with the ultrasonogram of the local part along with the contralateral parotid region and neck region.
So you would do high frequency ultrasound of the head and neck, especially the parotid area on the left side, right? So what is it that you want to see here?
I need to confirm the anatomical side origin of the swelling. I need to see whether it's a solid or a cystic.
So ultrasound gives you that there is a swelling in the area of superficial lobe of parotid of variable echogenicity. There are no enlarged lymph nodes. Anything else that you want to know?
Extension, whether it's adherence to the underlying muscle.
So no, there is no infiltration into the adjoining tissues. The plane between the veins and the tumor is well maintained. And the deep lobe is not apparently involved. How will you proceed?
Can you tell what are that adjacent tissue you are telling about? Can you go back in a order from the starting from the skin to the oral cavity mucosa?
The layers will be the first initial will be the epidermis, dermis, subcutaneous tissue.
Subcutaneous tissue.
Along with the
We
muscles.
just talked about it. SMAS is there in face. There is no subcutaneous tissue here.
Okay, ma'am. Skin, SMA system, which includes and then the facial muscles will be there.
Which muscle?
Buccinator muscle.
So you get directly behind which muscle? Parotid.
Masseter muscle.
Then?
In parotid region, after the masseter, there will be ramus of the mandibles.
Ramus of the mandible. Is any fascia comes? You heard buccopharyngeal fascia?
Yes, a buccopharyngeal fascia, and then the innermost is buccal mucosa.
In between, then?
Pharyngobasilar.
No. When you said that I am looking for the layers with the infiltration to the adjacent tissue, then you must know that each layers and what are the layers there, how you are going to look, how you are going to look for whether the gland, the duct is there, and whether it is any involvement which is there. Okay. Madam asked you said
Yes.
the high frequency ultrasound. What do you mean by that high frequency ultrasound?
The frequency used here is around 12.5 megahertz. 10 to 12.5.
So you have seen somebody is doing the parotid with the 12.5. We always say that the ultrasound is our stethoscope for the surgeons. So it is not that the ultrasonologist has to come and do. And you must try to use that opportunity to learn. Okay. Go back. Go ahead, madam, please continue.
Yeah. So any other investigation after you've done ultrasound?
For confirming my by ultrasound, if the features are benign and if only involves a superficial lobe, we can proceed with FNAC, guided FNAC, since the tumor is variable in consistency.
So is it mandatory to do an FNAC?
In this patient, since the duration of the swelling is around only 1 year.
So you see here, because we've given you a finding that it has got variable echogenicity, you're thinking in terms of pleomorphic adenoma. And clinically, it is unlikely to be a malignant one, so you may be able to avoid. But the advantage of FNAC in parotid swellings is sometimes you may encounter a cytological diagnosis of lymphoma, which you may be able to manage without surgery. Yeah, so that is the importance. Any role of MRI or CT scan in parotid swellings with these ultrasound findings?
By ultrasound, the deep lobe cannot be completely
You mean to
delineated.
say in all cases of parotid swellings, an MRI or CT must be done?
If we suspect any malignancy, we can go for MRI and CT.
So either if you're suspecting malignancy or if patient is symptomatic with history of difficulty in swallowing, or on clinical examination, you find features of deep lobe involvement, so you may want an MRI. What is the advantage of MRI over CT?
By using MRI, we can easily identify the perineural invasion and perineural spread of the tumor.
How is perineural invasion identified on MRI?
The tumor involves a nerve. There will be enlargement of the thickening of the nerve will be there, and then
No,
there will be,
not at all. Not at all.
there will be enhancement of the perineural.
No, because there is an indirect evidence on MRI because the veins get altered. An alteration in the appearance of veins is an indirect evidence of involvement of nerve. You do not see direct involvement of nerve on MRI. Yeah.
When we are suspecting, and you said that you will do CT in the case of malignancy. What is the objective of doing that CT?
But bony invasions, early cortical invasions can be easily, and a lymph nodal be easily made out by the CT, sir, comparing to MRI.
No, which when something is involved that you can't do the surgery, sir, you will be defer the surgery.
Bulb base involvement and the pterygoid plates involvement.
So you need to look for the pterygoid space, that is involvement, how it is involved. That is one of the major indications where you are going to do.
Yes, sir.
So can you tell us the spaces where the parotid tumors can extend? Normally, parotid is confined to parotid area. So what are the other spaces where it can extend?
Masticator space. It extends medially to the infratemporal fossa and then the masticator spaces.
It's temporal, pterygoid, and parapharyngeal spaces.
Parapharyngeal spaces.
Yeah. What is this facial-venous plane of Parotid?
It is a plane between the superficial and the deep lobe of the parotid where the facial nerve and the venous structures passes.
What is superficial? What is deep?
The facial nerve is superficial, ma'am, and the retromandibular vein is deep to the nerve.
How is that vein is formed?
It's formed by the fusion of the superficial temporal vein and the maxillary vein.
How it continues?
And it continues to the parenchyma of the parotid, and then it divides into anterior and posterior divisions. Anterior division joins a facial vein and forms the common facial vein. Posterior division joins the posterior auricular vein and forms the external jugular vein.
Okay, good.
Yes. So now on all investigations, you found that superficial lobe of parotid is involved. What is your further plan of management?
After confirming the diagnosis, since it's benign, I will explain the patient and proceed with superficial parotidectomy.
What will you explain to the patient?
Regarding the nature of the lesion and
so I'm the patient and I'm telling you, doctor, is there any need to operate? It's a benign swelling. It isn't too big. I'm not bothered about the pus vessel.
Benign swelling, if it is long-standing, there is a chance for malignant transformation.
So you would explain that there is a chance of progression in the size of the lump. There can be rapid increase. There can be other complications like skin involvement and a malignant change, right? And so you would recommend that the treatment is? Is surgery. However, you may defer it for some time. Better is to get operated, because as the swelling will increase in size, the surgery will become more difficult. What consent will you take from such a patient?
Regarding the facial nerve palsy, facial asymmetry, and then chances for the parotid fistulas. And then
so consent taking will involve all these steps. Okay, what is the indication of surgery? What will happen if you do not operate? What are the complications? And each complication, not just with respect to facial nerve, you should also talk about development of parotid fistulas and Frey syndrome, right? So all complication, presence of a seroma, and plus SSI like in others. So all complications must be explained, not just facial nerve palsy. Right.
What is
So,
the
and
possibility?
what will you explain in detail about the facial nerve palsy?
There's a more chance for the neuropraxia. That's most of the time the patient may regain the nerve function by 3 to 6 months.
Good.
But also there is a chance for nerve injury.
So, what are the types of nerve injuries that you know of?
Neuropraxia, axonot muscles, and neurot muscles.
Right.
Is neuropraxia?
Neuropraxia is a transient functional paralysis of the nerve, either because of compression of the nerve.
Okay. So suppose the patient asks you what percentage of tanning malignancy is the possibility. Suppose he has a pleomorphic adenoma. What is the duration and how long after that it can turn malignancy?
If the duration of the swelling is around 10 to 15 years, there's a chance for 5 to 10% chance for malignancy transformations.
Okay, the first 5 years it is very, very less, 1.5 to 2. So
2%.
if the more the duration, the more possibility.
Yes.
Is there any quantitative way of assessing facial nerve injury?
There is a House-Blackman system.
Yeah. So, can you grossly tell us what all is seen and how does it help you in evaluating recovery also?
It involves we have to examine two regions, from angle of the mouth and the eyebrows.
So basically what you can think of is you can divide it into upper, mid and lower face involvement, and recovery will happen in the same sequence if you look for it. Right? And otherwise you can go into the details. There are many parameters in it. Yeah. So what surgery will you plan
Lot
for
of
this
scores,
patient?
0.25 for age and other things.
I will go for superficial parotid, conservative parotidectomy.
Which
Any
term you are
other
referring to?
option? It is swelling is confined to the lower lobe. Do you have any other option?
Extracapsular parotidectomy. Superficial
Extracapsular
extracapsular.
limited parotidectomy is an option of swellings that are confined to the lower pole, but this is a relatively larger swelling. So you're right, the superficial parotidectomy is the. Why did you say superficial conservative parotidectomy? Is that a term? Is that a terminology that is there? Is there any other type of superficial parotidectomy also in which nerve is removed?
So non-conservative superficial parotidectomy is there?
Superficial parotidectomy. If you remove the whole parotid in a benign swelling, then what will be the surgery called? That will be total conservative parotidectomy, right? So superficial parotidectomy is a conservative parotidectomy only.
Why not excision? Why do you want to go for a superficial parotidectomy?
Because there is more chances for the recurrence in case of pleomorphic adenoma, sir. So if you just excise the tumor, there is a chance, high risk for recurrence.
Recurrence means you're saying it's malignancy.
Even in case of benign tumor, pleomorphic adenoma has a high risk for recurrence.
Why?
Why?
Because of the presence of the pseudopods beyond the capsule, the tumor cells may be extending. So the more prone for seedling, when we excise the tumor alone, there's a more risk for seedling of the tumors and incomplete removal, or the presence, the pseudopods will be retained, so there will be an increased risk of recurrence.
And also regional limited excisions are associated with more nerve injuries. as compared to
Uh,
superficial
in case-
parotid. How do you identify the facial nerve trunk during parotidectomy?
By using some landmarks, either by using the tragus, the
So you
facial
have
nerve,
you know the landmarks. We'll come to that later.
Okay.
How do you, by appearance, identify the
it will be a,
facial nerve?
whitish,
So you see
elongating
it as a pearly white glistening structure. Why is it? How do you say that that's the trunk of the facial nerve and not one of the branches?
by thickness of the nerve.
No, you have to trace it further till you see the
Sure.
bifurcation.
Bifurcation.
Yeah. If you're not able to see the bifurcation, you may be dealing only with one of the branches, which may be a major branch, right? So you have to trace it till the bifurcation to call it the trunk of facial nerve. Is the facial nerve present? What is the relationship of facial nerve to styloid?
The facial nerve exits via the stylomastoid foramen.
No. Is it superficial to it? Is it deep to it? To the styloid process?
It's deep to it.
Not at all. You are not supposed to go below the level of styloid process in any parotid, in superficial parotidectomy. Facial nerve is present, superficial to the styloid process.
Okay.
Right? Okay, now you tell us the landmarks that you've been wanting to tell us. Identify facial nerve.
By using the tragus, the trunk is 1 centimeter below and deep to the tragus now. By styloid process, we can trace the facial nerve, and the facial nerve will be found just superior to the posterior belly of digastric.
How will you identify
muscle.
that muscle?
By the orientation of the fibers. From the mastoid, it will be going anterior.
It's against the orientation of sternocleidomastoid.
Sternocleidomastoid.
Are you are interested only on the facial nerve or any other nerve you are interested also when you are doing a parotid surgery?
We will encounter greater auricular nerve.
Okay. And how do you identify that? Where is that point?
Usually, from the anterior margin of the sternocleidomastoid, it will be.
It starts with the anterior margin.
No, it starts from the posterior margin of the sternocleidomastoid, sir.
What is that point? Where do you get F's point?
Oops, point.
That is on the posterior border, almost 6 centimeters below the tragus of the ear. You get.
Junction of the upper third and the lower two-third of the sternocleidomastoid.
So which nerve you will preserve? In the greater auricular nerve, what point of the nerve you will preserve? It divides into anterior and posterior branch.
Posterior will be preserving.
So what is the function?
Sensory supply to the auricle.
What sensation it supplies mainly? It mainly helps in the identification of the climate, I mean, cool or hot. So especially the people who are over the scuba diving, that people that they will not be able to feel the temperature variation. It is mainly it affects the temperature sensation itself. So you can identify any other way other than that what you said. Any artery?
The branch of the posterior auricular artery, the styloid branch of.
Styloid branch. So that will also one of the other way that you will be able to do that. So all that Connolly's pointer, all that you have said that. So is there any way I am trying that I couldn't identify that nerve at all?
We can trace from with the retrograde method. We can trace from the branches.
Okay.
So, what is the point of cutting this greater auricular nerve? Why do you want to cut it? It's called to convert necessity into a virtue. So you tell us what is the necessity and what is the virtue in it.
If the nerve enters the parenchyma of the gland, or if it
No. Don't cook stories. The thing is, necessity is to be able to mobilize the tissues properly so that you can reach the parotid area, right? And the virtue is that you preserve it in saline so that in case there is any nerve injury, you can use it as a graft.
Right.
And you preserve it in saline till the end of the surgery, right?
Yes, ma'am.
Yeah. So we were talking about if you're not able to identify facial nerve, one is that you said you trace it retrogradely. We had told you earlier, we'll come back to it later when you said that the swelling is reaching up to the mastoid. Now, if the tumor is occupying the retromandibular groove and is over the mastoid, and you're not able to see the trunk, is there any other way you may want to seek the help of your colleagues to identify facial nerve?
Explore the mastoid.
Yeah, very rarely required, but you may need to go through the mastoid to be able to identify the.
It will be purely white there also.
Sorry. It will be purely white.
No. The color in the mastoid is a little different. It's not the
Okay,
typically. Good, good, good. So you have an option that you are tracing the nerves, but all the 5 you couldn't trace. And which one you can sacrifice, which one is ideally we should not. But if at all, then you need to allow to sacrifice. Upper
These
trunk,
were
lower
the
trunk.
buccal branch, lower trunk. In that lower trunk, the buccal branch, if we can't sacrifice, there will be no much impact on the patient.
So actually, there is this in upper buccal and lower buccal, and there is an interbuccal branch that connects the two. Especially if the deep lobe is involved, this interbuccal branch connecting the upper buccal branch and the lower buccal branch can be transected.
The parotid duct goes through which buccal branch? How it?
Upper buccal, it goes along the upper buccal branch.
Suppose you cut the marginal mandibular, what will happen?
There will be a loss of sensations over the angle of the mandible.
So is it a sensory nerve? Facial nerve is a sensory nerve?
It's a mixed nerve.
Mixed nerve. What is the sensation facial nerve produce?
Taste sensations.
Face sensation.
Taste sensation by chorda tympani.
Chorda tympani, yeah.
That is a really different one. We are not talking about that senses. No? That is a special senses. By virtue, it is a mere facial nerve is a motor and trigeminal nerve. We consider mainly as a sensory nerve.
Okay.
Yeah. So what are the, why must you specifically avoid spillage of tumor during parotid surgery?
You're asking regarding what are the steps to avoid spillage?
Yeah. No, and why must you specifically be very cautious to avoid spillage in a benign swelling? You're thinking in terms of a benign swelling and you still want to avoid spillage. When you do a sebaceous cystic ruptures at times, you're not so bothered, no? But here you're bothered.
We have to raise adequate flap till the anterior border of the parenchyma.
No, because if there is spillage, that becomes an indication for radiotherapy, even in benign swellings. So you have to avoid spillage at all costs. Right?
Okay.
Yeah. So once you have resected, you would want to trace the whole parotid over the nerve till you see the nerve branches entering into the respective muscles, right? Do you need to lift up the nerves or hook them up while you're doing parotid surgery, or you work above them?
We used to work above the facial.
Yeah, so you don't need to hook up the branches because that will lead to neuropraxia, right? You work above, above them. So what about any specific thing you may want to do regarding the hollow that is left in that area after you've removed the parotid? There's a hollow that remains there.
We can just approximate the fascia, and there will be no that. Then there will be not that much disfigurement.
Yeah. So you may leave it as such, or you may use regional muscle flaps to cover that area, or you may use interposition grafts. What are the other advantages of using either a muscle flap from, say, say, masseter or an interposition flap? Any other advantage other than,
The
Ray's
contour.
syndrome can be avoided.
Okay.
sorry?
Ray's syndrome can be avoided.
Yeah, Frey's syndrome can be minimized like that. Any
What is
other
it?
steps that you can take during surgery to minimize Frey's syndrome?
By while raising the flap, adequate thickness should be maintained.
Yeah. And the length of the incision also matters. Well, what about
incision you prefer?
Sir,
What incision you prefer?
modified Blair's incisions.
What is that modification? Blair and modified Blair?
The Blair's incision just involves only the vertical component of the incision. In modified Blair's, we are making a vertical component just in front of the tragus, and then horizontal component in the 2 centimeters just beneath the body of the mandible and the cervix, the neck, and another component joining these two.
Even the vertical component is not straight. No, it goes along the contour of the outer contour of the ear. Can you cut?
It turns posterior and superior along the just beneath the ear lobule and then reaches the mastoid and
Yes.
then.
So the three components of the incision are the facial, the mastoid, and the cervical. Out of these, which is the one that you start with?
Cervical.
You do the cervical, you do the facial, and then you create 2 hollows there. And after you've completed the mastoid part, what is this term called whittling? Have you heard the term to whittle away tissue?
No, ma'am.
So in between these 2 cavities, there is a fibrofacial layer. So you take it millimeter by millimeter as you proceed to be able to identify the facial nerve. So hooking it millimeter by millimeter and then cutting is called whittling away this tissue. Right? That's the easiest way to do parotidectomy. You create a hollow in front of the tragus. You create a hollow in the cervical area. In between these 2 cavities, there is this fibrofatty tissue, fibrofacial tissue actually, not fatty. And when you whittle it away, it takes you to the facial nerve.
Okay.
Yeah. So any specific way, dressing technique by which you may be able to avoid any complication or a sequelae of surgery?
Avoiding tight dressing should be avoided.
So what you can do is you can apply a soft pressure dressing because seromas are known to happen in this area. So what are the types of fistulae that you know of, salivary fistulae following parotid surgeries?
Following surgery, the fistula may be either from glandular or else from the duct.
Yeah.
Ductular fistula.
So which is more
glandular.
dangerous? Which is more dangerous out of the 2?
Ductular fistula, there will be more output will be there and then.
So why? What is the difference in identifying the difference between the 2?
The position of the fistula, whether it's more
So
towards the
parenchymal fistulas may be managed by conservative methods. However, ductal fistulas may need some kind of a repair. What are the various surgical procedures that you know for managing salivary fistulae?
We have to by probing the fistulas and then we have to
So the procedures may be either ablative or they may be diversion procedures, right? Ablative procedures would include either ablation of the gland. There is no gland only, so there will be no secretion, so nothing will come out, or ligation of the duct. While diversion procedure would mean you may divert the duct at the site of fistulae into the oral cavity, right? And then reconstruction procedures are also there. What are the various nerve reconstruction techniques that you know of?
By primary suturing or by grafting.
So which suture material is used and what number?
Ma'am?
What number suture material is used and how is the suturing done?
Uh,
So you need to see the type of nerve injury and you need to see whether there is loss of a segment of nerve or not, right? And because loss of a segment would mean you would need a graft, right? If there is no loss of a segment in transection, then you do a microscopic repair and a 10-0 suture material may be needed. And repair is better done under a microscope than without it. What are the types of nerve grafts that you know of?
can go for greater auricular nerve or the sural nerve.
So one is if you take a single nerve and you have an appropriate sized nerve, you can use that. Okay. But if the main trunk is injured, just one nerve may not suffice. And you may need multiple nerves and use them as a cable graft.
Okay.
I think you've presented very well.
Extremely well.
Well done.
Dinesh, you are, really good. It was almost your confidence with which you answered and the depth which you know. That shows that your active involvement in the ward also. How do you see? How do you identify somebody is developing the Fraze syndrome or that? Can you make it out?
The test, sir.
Yeah, test and what will be their complaint?
Usually they will complaints of excessive sweating in the parotid region, especially during the food intake.
Is it only on the intake?
Whenever the patient gets impulse on seeing the food, whenever the salivation is increased,
not only just taking the food inside, even the smell, even the whatever they see can produce on that. So, what are the treatments options available?
Antiperspirants, anticholinergics, and we can go for tympanic neurectomy. Botulinum toxins can be given.
Any role of botulinum?
Yes, sir. Botulinum toxins can be given injected.
Yeah, madam, please go ahead.
Yeah, I think he's done well, sir. Supposing it were a malignant parotid swelling, what surgery would you have planned for him?
Total conservative parotidectomy.
Sorry?
Total conservative
What
parotidectomy.
is the difference between radical parotidectomy and total conservative parotidectomy?
In total conservative parotidectomy,
Conservative parotidectomy is not the management of carcinoma parotid. Total conservative parotidectomy is the management for benign parotid swellings involving the two lobes. Treatment of malignant parotid would be?
radical parotid.
See, radical parotidectomy, you may excise facial nerve also, but a component may be that you preserve the facial nerve, but at the same time, neck dissection is mandatory. You have to do MRND with it.
Yes, ma'am.
That is the difference. You may preserve the facial nerve. When is the facial nerve excised?
If the intraoperatively the tumor is infiltrating the trunk of the facial nerve, or in the preoperatively the patient.
Yeah, if you have features of infiltration, clinical feature, a facial nerve that is functioning is not removed.
Yes, ma'am.
Yeah. Basically, neck dissection must be done along with it. And if there is regional involvement of, say, pinna, that part may need to be excised along with and may need a reconstructive procedure, which may be a plastic reconstructive procedure along with it. Again, multidisciplinary team involvement is important to be able to plan.
Dinesh,
Indications of radiotherapy?
In case of a high-grade tumors, nodal involvement,
High grade?
margin sensitivity. If the margins are involved,
Yes.
in case of any
And spillage during surgery. Yeah.
Perineural invasions, lymphovascular invasions.
Yes.
Dinesh,
Sir,
in any other parotid malignancy, swelling, facial nerve is removed, clinical types, histopathological type.
sir, I can't hear you, sir.
In which parotid tumors we need to remove the facial nerve? Pathological types.
In adenoid cystic carcinoma, there's
Okay.
more chance of perennial invasions.
Okay. And mucoepidermal. Thank you.
I think Kanavel sir, you are here.
Sir is not here, sir.
Okay, Dinesh,
I think
done extremely well. Do you have any questions? Because on the parotid.
And regarding the surgery for malignancy, during evaluating the patient itself, we are finding that there is no evidence of extraglandular extension of the malignancy. So we are planning for surgery, and we are removing the superficial and deep lobe by preserving facial lobe. In this situation also, we need to say it as a radical parotidectomy, or there is no evidence of local spread preoperatively, ma'am. So in that situation, we need to say it's total conservative, right?
You can see, but you need to add MRND to it.
Okay, ma'am.
You need to add, you cannot call it only total conservative parotidectomy. Then it has to be total conservative parotidectomy with MRND.
Okay.
Which term you prefer now, madam? Comprehensive neck node dissection or is enough MRND?
No, sir. It is what we do is a selective node dissection, sir.
Okay. Okay.
Then in modified radical neck dissection and type 2, in some books it's given as nerve and vein are removed, and some books given as nerve and muscle are removed. And which one is correct one?
Sorry?
In MRND type 2, some books it has been given as nerve and muscle are preserved. In some book it's given as nerve and vein is preserved.
No, all the three should be preserved. Nerve, vein, huh?
In type 3, it's all three is
Yes.
preserved, ma'am. Type 2, it's either vein or muscle.
So we need to vein and nerve are preserved.
Okay.
I think someone else can take it. Wouldn't want to give you a wrong answer. We will read it.
Thank you, Dinesh.
You specify what exactly you are doing. I think that is more important rather than going into the semantics of words.
Good.
Can we call it a day, sir?
Yeah, I think one more presenter is there.
Or one more presenter is there?
Yeah.
no, sir.
Only
I
one.
think today only one is.
Okay, fine. Then usually we used to have. So, Dinesh, thank you for presenting.
Dinesh.
We are literally happy that you are able to answer many of the questions and you are able to be very
It was
confident.
really excellent presentation.
Convey our
He
regards
answered
to your
all
HOD.
questions very well.
Thank you, sir. Thank you, ma'am.
Okay,
Thank you.
fine. Well done.
Thank
Good
you very
night.
much, faculty.
Thank you.
Professor Ratna Madam, Professor Jailal sir, Professor Jagmohan sir. With the faculty permission, can we close this session?
Sure,
Please.
sir. Thank you.
Good night, sir. Good night. Thank you
Good
very
night.
much.
Good night, everyone.
Good night. Thank you very much.
Good night, everyone. Thank you very much, sir. Thank you for conducting the program. Good night.
Good night.